お待たせいたしました。
Thank you very much for waiting. We'd like to start the first session on possible paths to adopt, achieve, and sustain UHC. 11 countries with different degrees of introduction of UHC to introduce policy objectives, and how are they trying to achieve this? We have the lead health specialist, Health, Nutrition and Population Global Practice World Bank Group to speak, Ms. Akiko Maeda. So the floor is yours. I'd like to thank you very much for having taken time out of your busy schedules to be with us. My name is Akiko Maeda from the World Bank, and today I'd like to talk about the joint research. I'd like to be very brief. On universal health coverage, the partnership between Japan and World Bank has the objective, and this was we're into the age of post-MDG toward 2015, and to the low and middle-income countries, there's a lot of interest in universal health coverage. And these countries to implement and formulate policies. What kind of advice can Japan offer, and what kind of support can Japan offer in terms of investment? This is the objective. On UHC, there are 11 countries at different stages of UHC who have participated, and in terms of the topic, we focus on three areas. That is political economy, financing, and health workforce. So we focus on these in these three areas. And we would like to identify and share lessons. First of all, the framework for analysis. As is shown here, there are these three challenges. Medical financing. This is an area where the World Bank has been engaged in different kinds of analysis for an extended period. And something new, health service with regard to health and medical human resources is something that we have analyzed anew. And with regard to the political economy and policy, what range or breadth would be possible? That is what we decided to analyze. The 11 countries that have participated are at different stages of UHC, but they can be categorized into four major groups. The first group comprises Bangladesh and Ethiopia and such countries where they are in the initial stages of UHC and with limited resources. The two countries listed here are representative of these countries. And then the second group, Ghana, Indonesia, Peru, and Vietnam are participating in the second category. Initial programs and systems for UHC are in the implementation stage in these countries, and they are re-evaluating, and they are looking at the uninsured and underserved population group, and they're confronting various challenges in extending coverage to these persons. Third group, Brazil, Thailand, and Turkey. These three countries have a strong leadership, and there's a strong will on the part of the public to obtain universal coverage, and they're close to attainment. And these countries are such that in terms of quality of medical service or fairness and fiscal sustainability, these are the challenges. The fourth group, that's Japan and France. It's been many years since these countries have achieved the UHC, and they have a mature system. But they've seen a slowdown in economic growth and aging of the population, inclusive of the working population, inclusive of the labor force. These are new issues being encountered by these countries. On the health workforce, let me talk about the 3 points related to this. Finances is, of course, important. But the shortage of human resources is an issue for the middle, high, and low-income countries, which are constraining factors to achieving UHC. Through UHC, there's a lot of demand for medical services. And so with regard to the basic medical service, they face a widening gap between supply and demand. Even if they were able to increase human resources, they don't have the finances to sufficiently employ these people. In the middle and high-income countries, economic and demographic factors have changed, and increase in demand and the gap between demand and supply of human resources is being faced by these countries, as was the case of the low-income countries. But in these countries, increasing medical costs and medical and health human resources transfer and mobility is a change. Shortage of human resources. In order to expand this, it's not just a matter of increasing the number. Through technological development, there's more demand for higher skilled workers, which is taking place worldwide. And if we do not regulate the labor market, we will see uneven distribution of medical personnel. In the emerging countries, there's a rapid and unregulated growth in private sector entry into health and professional education with little quality assurance. And community health workers and other workers, the securing of a broad range of human resources and the educational system must be suited to the locality. And we have to focus on the local needs in terms of education as well. A third point with regard to human resources: remote areas or where areas where there is meager medical resources, the employment of medical services personnel and career development. We need to promote that. In unregulated markets, medical personnel employment and education tends to focus on urban and higher income areas. In order to rectify the imbalance in the distribution of medical services personnel, we need to do many things. We need to increase the educational level. We need to improve labor environment and living standards. And we need to employ these strategies. We need to create career incentives so that personnel can accumulate career experiences and promote active recruitment of students and workers drawn directly from underserved communities. And these are important challenges for going forward. What I have shown here are the three countries: Brazil, Thailand, and Turkey. Brazil, Thailand, and Turkey, as mentioned earlier, are such that with regard to UHC, they have a high degree of establishment. By focusing on primary care to improve access, control medical expenses, they have been able to achieve UHC, and that's an important lesson that we can draw from their experience. And by focusing on primary care, where in communities where there's scarce medical resources, employment and educational opportunities must be provided, and this will become increasingly important going forward. The Ebola disease is such that because they didn't focus on the areas indicated, they have seen the rise of different problems. you have to educate the medical resources on a broad basis, and you have to distribute them to different places. And that approach, we feel, is effective. With regard to these approaches, effectiveness and efficiency is something that we need to verify more going forward. For example, in our research, Ethiopia's health extension worker program was very much under focus as a new approach from the world. On finance, we have to deal with market failure, and in order to achieve a UHC, governance, the necessary governance must be put in place. Regardless of the income level of the country, there are constraints on resource. In order to attain UHC and to maintain that, you need to provide medical services which provides value for money. For example, a public health type of strategy investment is important for any country. And through this, prevention of Ebola or such programs are very important. And that is the message we want to communicate. In any case, medical services are based on data has to be selected. Political and market pressures must be such that there has to be governance to contain that. In finance, there are many countries where multiple number of medical insurance systems are being consolidated, and the coordination is becoming a major issue. There are different countries shown here: Ghana, Vietnam, Indonesia, and Peru. These countries, up until now, had different systems and institutions in existence, and they're trying to integrate all of this. And the actual integration is a very difficult challenge politically as well. For example, Vietnam. In 2009, they created a medical fund for low-income bracket, and they integrated that with social medical insurance. And the benefit is still different for the two systems, despite the fact that they have integrated. And these are due to political and technical issues. Japan has, over 10 years, maintained a multiple number of programs and systems. And as you know, a new policy is being studied, as you are aware. And lastly, toward the UHC, we need to measure progress and promote accountability. And that's an important responsibility of the government. As countries commit and move toward UHC, there'll be different interest groups. We need to create a governance structure where the different interest groups would show an understanding. And that is very important for achieving UHC. A political compromise or fiscal pressure. This is if this excludes certain people from the insurance scheme, or if the benefit level is reduced and there's increased co-payment, and this happens very frequently at various points. How the policies are being reflected on the people is something that needs to be elucidated, and that is very important. And lastly, for the respective countries toward UHC, a means to measure progress has to be leveraged. And revisions and fine-tuning is very important, and that would be key to UHC. These are difficult issues, but by sharing experiences of many countries, we want to take a lot of research and learn from the Japanese researchers and the Japanese government in moving forward. The specifics are found in the document that has been published. So please go to the website. Thank you very much for your kind attention. Thank you very much, Ms. Maeda.
We will move on to the next speaker. That is Dr. Michael Reich, Professor of International Health Policies, Harvard University. Professor Reich, the floor is yours.
Tadaima.
Thank you very much for your kind introduction. I am Reich from Harvard University. Pleased to meet all of you. My presentation, I will try to do it in Japanese. First of all, the research project, I'd like to explain that. It's a complex, comparative study of UHC in 11 countries. The studies were conducted by researchers in the World Bank in Japan and the 11 country teams. In particular, I would like to thank the core members. My hearty appreciation to the members of the core group. Some of the names of the core members are written on the slide. Now, political economy perspective is something from which I would like to draw some lessons from the project. The key points, as you see in the slide, would be UHC. The process of attaining a UHC means who gets what. So in order to change who gets what, UHC must involve not only the technical processes, but it must involve a redistribution of resources in society, values, social values, and political processes. In the final analysis, the UHC means the redistribution of resources in society, and also it is the trade-off with various actors in the society. Simply put, basically, the process of UHC is the political economic process. So this is the key point. This should not be forgotten in this field. So I would like to take 6 lessons on political economy of UHC. Very briefly, I would like to explain those 6 lessons. First lesson. Lesson number 1. As was mentioned in Ms. Maeda's presentation, you saw the same table. 11 countries were divided into 4 groups. And then for each group, we would identify the common political and economic challenges. The first group, the adopting UHC would be the goal. So it is the agenda setting phase. The second group is expanding coverage of UHC. So in this group too, there were common challenges. The third group, they would like to reduce inequities in the coverage. Amongst the countries, there are some common political and economic challenges we found out. The fourth group, that's Japan and France. So they have a continuation of the political economic challenges. So UHC is not only an endpoint. UHC is a process. So what we want to send out as a message is that UHC is a process. Lesson number 2. This is the cube as defined by WHO regarding UHC. It's called WHO UHC Cube. In this, as you can read, the UHC cube has 3 axes. And they would represent a very serious confrontation between three factors. The first is the population covered. Which population groups first receive coverage? Which groups receive a priority in incremental expansion of coverage? That, in the end, would entail not only the technical process, but the political and economic process. The second axis, the services covered by pooled funds. What are the services covered by the pooled funds? How are benefit packages decided? Which services are covered for which population groups? And the third element, or third axis, is the proportion of costs covered by pooled funds. What are the premium or copayment levels for different population groups? To what extent do different population groups receive support from central tax revenues? These decisions on who gets what are deeply influenced by political economic processes and by social values. Continuing on, lesson number 3. Problems of fairness and equity persist as a country moves toward UHC. These are the problems that these countries will face. In the final analysis, I mentioned 4 groups. The countries belonging to these groups, depending upon their stages, they will be faced with the changing fairness or equity. The distribution of resources along the 3 UHC dimensions creates issues of fairness and equity in society. Economic growth and favorable macroeconomic conditions help with coverage expansion, but they are not a sufficient condition for ensuring equitable distribution of coverage. So that in itself is not enough. So countries need policies that redistribute resources and target subsidies to reduce disparities as they move toward UHC. So that kind of national policies are required. Lesson number 4. UHC drivers. Where would it come from? Political leadership and the social movement. So, conclusion of the research is that strong political leadership combined with social movements helped to overcome economic constraints and competing policy priorities, thereby moving countries toward universal health coverage. So countries can come closer to UHC. So 2 country examples are shown. Brazil Sanitarista movement and Thai's Rural Doctors Society movement. So where are the drivers of these cases? It is not only the political leadership and social movements alone. So if you look into the Japanese and Ghana examples, there was a movement of top-down direction. So it was not only the social movement. The political parties also competed amongst themselves, and that competition can become the driver. Lesson number 5. Health insurance schemes tend to persist once created. So that's the tendency. As a matter of fact, one organization is created, then for that organization, the survival and the maintenance, there is less possibility of that organization to be eliminated. So countries with multiple programs face challenges in harmonizing contributions and benefits across groups, making it difficult to improve equity or fairness. Concrete example would be found in Japan. Various groups would like to maintain themselves. So that is the positive feedback loops that organizations would create for ensuring self-survival. So it is called that leads to the phenomenon of path dependence. So as a matter of conclusion, once UHC begins, which organization would be the starting point? You have to consider very carefully which organization to start, because that organization will have a very small likelihood of being eliminated. The last lesson, lesson number 6, creating the capacity to deliver services is critical to maintain legitimacy for UHC. So again, 3 countries are shown as concrete examples, as you can read. So various countries would have policy legitimacy, and to that end, delivery becomes very important. Implementation becomes very important. Especially in Brazil, Thailand, and Turkey, primary care was regarded very important. Universal health coverage's effective development was supported by these countries' implementations. So this is the conclusion. Very simply put, my conclusion is as follows. UHC, the efforts by countries to move the UHC process needs a political and economic analytical perspective. You need analysis in order to understand the UHC. In order to promote UHC, you need to have political and economic perspective. And also you need a strategy to go for UHC process. As you can read on this slide, in order to pursue UHC, it's not one path alone available. Depending upon the countries, depending upon the country's historical, political, and economic situations, the path toward UHC would become different. Therefore, various countries need to help the attainment of UHC, and they have to assure a fair distribution of resources, and they have to have a policy for policy adjustments, strategy for adjustments, and you have to have social values to guide progress toward UHC. In this presentation, this was only a summation of what I wanted to present. So if you want to know more about it, please refer to the report itself. Thank you very much for your kind attention.
Thank you very much, Professor Rai, for that. Please move back to the table over there. We would now like to have a session for comments and questions. Our commentators are Mr. Kiyoshi Kodera from JICA, and Professor Shibuya from the University of Tokyo, and from Joseph, Managing Director, Mr. Sumie Ishii. Please come up on stage. Thank you very much to you all. We'd like to have comments on the presentation just given. Could we start with Vice President of the Japan International Cooperation Agency, Mr. Kiyoshi Kodera, please. The floor is yours. Thank you very much for the kind introduction. Initially, I'd like to talk about the 15 years that JICA went through. Ever since the MDG has been adopted, what has JICA done? And universal health coverage, the concept and the emergence thereof. And how did JICA respond to this? And what is JICA about to do? These are the central points of my talk today. First of all, for over a decade or so, the health sector is such that, in a sense, within development aid has been a lucky sector. We were able to collect a lot of money, and JICA was involved with mother and child health and AIDS and malaria and other infectious diseases. We extended technological assistance in various countries in these areas. This is the containment of diseases. That's a vertical attempt. And the horizontal axis, what to do about health personnel. The horizontal axis and how to bring this together was an area where sufficient work was not done. But with regard to the vertical axis, we had to achieve the MDG, and we are seeing results, I believe. So, the health personnel, strengthening a referral system and enhancing primary health care is what we've worked on. But why is the word universal health coverage so important? The poor to have to make a lot of co-payment to be further reduced to poverty. That goes against our central challenge of eradicating poverty. It's not only about medical, it's the medical finance, medical system, and medical public finance and medical administration. So ever since UHC has emerged, we have been engaged in advocacy efforts from spring to summer of this year. In various places, there were UN leaders who have come to Japan, and we show the JICA position post 2015 major objectives has been summarized into one sheet, and we've presented this to them. And in it, clearly, we have indicated the attainment of UHC is one of our objectives. However, the universal health coverage, how to feed that into operations is something that we have to learn by doing. We are running and learning at the same time. And so this World Bank report came out, and I was looking at this synthesis report. Most probably Japan's Ministry of Finance funded World Bank with regard to many as research. It's 1993, there was the East Asia Miracle, and since then there was this is an epoch-making report ever since the last one. And at the time, whether that report would be financed or not, Mr. Moma was involved in this. He is director of the Ministry of Education Fiscal Research Institute. He's leader of that now. But he had to make the decision as to finance. And as a result, this report turned out to be something quite outstanding. Professor Reich talked about looking hard at the political economy and the consequences of that. And Mr. Maeda talked about Ms. Maeda talked about the human resources and the systems for thinking about this. Very interesting 11-country study has been made, and 4 typologies have emerged out of this. The respective country system and our operation. When we think about our operations, this will serve as a very important guidepost. Professor Reich referred to the WHO UHC Cube. In JICA, for example, when we think about a certain country's program, this UHC Cube will be referenced to see how operations ought to be. Well, we're still in the process of doing that. We haven't come to a conclusion as to what we should do as a result of this, but this cube and the 4 typologies in our future operations will assume a major significance, and that is without a doubt. Since 3 years ago, going beyond the technological assistance. We wanted to scale this up. Pakistan's polio operations, we've started yen financing. And last year, the Japanese government, with regard to health yen loans, said that it would reduce interest rates so that it's close to a grant. It was an encouraging factor for our operations. The government seems to be moving in that direction. But when it comes to build up of personnel, that can be done. But based on UHC concept, to say that this country is in this stage, and so the next stage is this stage, to be able to say that in terms of operations is something for the future. We've spent over a year or so, and we've worked on Kenya's universal health coverage. Kenya would belong to the second category, according to the categories explained. And the medical security expansion for these people, and expanding services in suburban areas or rural areas, and strengthening medical services. We're thinking about whether yen loans can be used to achieve this. What I want to emphasize today is that with regard to the 11 case studies, you shouldn't just read the portion that's related to the country that you're responsible for. You have to read everything between category 1 through 4. You will only find out the challenges for your responsibilities when you compare with others. And then you need to know about leading countries, and that these may prove to be important for the countries that are following along. There are 11 countries, and with regard to other portions, there are only summaries of the systems described. There's nothing that comes close to the description given by Professor Ikegami, but those who are in this area, who are studying this or who are implementing these, we hope that you'll read everything. And not only the health authorities, but the financial authorities or fiscal authorities, you have to consult with them for a significant program. And the National Institute of Public Health, as well as National Center for Global Health Medicine, these are our partners. And their human resources we'd like to cooperate with to develop and deploy a meaningful program. Thank you very much.
Thank you very much, Mr. Kodera. There are a lot of challenges going forward, and he spoke of various ideas of making use of this report for the future challenges. Next commentator is Professor Shibuya of Tokyo University of Tokyo. Good afternoon. I am Shibuya. I'm not good at praising people, but Sama Skill, the deputy editor of Lancet, very tough reviewer. I think this is the kind of report which should be praised even by severest and toughest reviewers. Congratulations. I heard various cases and scenarios. So if I was the politician of the countries wanting to achieve a UHC, I would be very happy. The young population, poor people, and providing insurance would be a good policy. So it's a win-win sort of agenda setting. But as Mr. Minorika and Mr. Takemi said, Japan is faced with serious challenges. But that has to be explained to the voters. That's the chore of the politicians. It's a very serious situation. But eventually, the countries in Asia, countries in the developing world will be faced with a similar situation eventually. So how are we going to make use of the report in a practical way? That is the most relevant point. What kind of organization should we have? What should be the benefit package? So if you purchase a vaccination set this much, then the problem would be solved. And is it okay to just set $5 a day for fiscal set? So there are various challenges which will be identified in the process. So practical roles will have to be played by countries. Japan will have to do that. And I think that is the most important and relevant point. The second point, governance related, as Ms. Maeda said, it's just like countries governance. When it comes to international organizations, UHC is a kind of buzzword, but who's going to lead it and who's going to do it? For example, WHO has a legitimacy, but in reality, can it do it? World Bank and World Bank and other groups. How can people coordinate and in carrying out the processes which will lead to UHC, including Japan? We have to consider that. The third point, Japan has a difficult road, but we have a role to play. That's something positive, not only negative things. So we have to share our own problems with the rest of the world so that we can provide possible solutions. For example, in fora like G8, we can present what we can do. That is all. Thank you very much.
Thank you very much, Professor Shibuya. With regard to future research subjects, not only the World Bank, but various agencies, how they are tackling these issues together, not only medical, not only Ministry of Health and Welfare, but from various sectors. There needs to be cooperation. Thank you very much. From JOSEF, we have Ms. Ishii next to present. Thank you very much for the kind introduction. My name is Sumiya Ishii from JOSEF. From the NGO perspective, I'd like to talk about what we need to learn and what we should think about going forward. From the NGO perspective, an important message, that was what I was supposed to give. So I'd like to raise 3 points. First, with regard to introduction of UHC. It depends on at all levels of economical and social development. It's possible to introduce UHC, and even low-income countries can introduce that. There are examples of that, and as we can learn from Brazil and Thailand, social movements can play a major role in promoting UHC. And thirdly, primary care, focusing on primary care would improve access and improve coverage. When we talked about primary care, there's the issue of quality and sufficient supply and accessibility of supply. It's a package. These 3 points are not sufficient, but there are roles which the NGO can play and NGO should play. Implicit in all of these goals are the roles that NGO should play. But having said that, UHC is such an enormous subject. There are 40 international insurance NGOs and advocacy, exclusive of large advocacy NGOs, on a project basis. In developing countries, there are small NGOs conducting projects. And of this, when we say UHC, they don't know in which framework they belong or where they could be useful. It's very difficult for them to think about this. This is a fact. Who will play what kind of role in what areas? That's not very visible. So from such a perspective going forward, issues we'd like to see studied more are the following. We hope that there'll be a follow-up to this report. So the next research items which we'd like to see included in future reports are the following. The residents, recipients of services, UHC promotion analysis from their perspective, taking the perspective of the community. We think that would be very favorable. In human security, there's the top-down protection and bottom-up capacity building or empowerment. They both have to come into play for everything to work well. So in that sense, the bottom-up analysis and report would be very favorable. We think that is what we would be looking for. These 3 areas have been a point of focus in the report. But even if we assume that all of these have been achieved, in many countries, unfortunately, women cannot go to clinics on their own will without worrying about the finances. If they could go on their own will, one of the major issues would be the social determinants of health. That needs to be in existence to enable them to go to clinics on their will. So if the analysis and the report includes this, it will be a complete UHC report. And among people, we believe that they will take ownership of this when this is achieved. What was interesting was that last year there was a midterm report which was given in December, and the position of Japan NGOs regarding UHO was asked of us. I didn't know what was meant when people first asked this question, because we take UHC for granted here in Japan. And even if we're asked whether we are for or against UHC, I was surprised to see that perhaps there was someone against the UHC. It was a shock for me. But what I thought about was that when people hear UHC, it's hard for them to imagine how things will be when UHC is completely achieved, and that is what I thought about. So among the things that we could do would be the following: to describe what UHC is and the situation where UHC is achieved. Professor Rice talked about the process. When the process is going relatively favorably, what can be expected? Inclusive of these points, we feel a need to advocate. So those of you who are here in this hall, we'd like to solicit your cooperation on the 12th of December this year. U.S. NGO and world NGOs, 100 of them all, will be assembling to have a UHC day. And in Japan, we want to make this a success and add momentum. Through social media, we'll be calling on you, communicating with you. For those of you here, I'm sure you know what the UHC is when you're given this acronym. But then not everyone understands what the UHC is when they're given the term. So that as many people as possible can know about the significance of UHC, we want to make this program a success. So we solicit your kind cooperation. Thank you very much.
Thank you very much, Ms. Ishii. I just found out in a country like Japan, UHC is continuing for some time. In a country like Japan, citizens are not able to visualize what the UHC is all about. But if you go to the United States, there is a shocking situation. There are a lot of people uncovered with insurance. It's not only happening in the low-income countries. It's happening in the United States too. It's not only economy, it's an economic giant, the U.S. is, but U.S. was not able to achieve UHC. There are political reasons to that. So citizens, civil society, NGOs will have to develop their movements to attain that goal. I really felt the importance of that.
Michael, would you like to make some, at this stage, would you have any comments or response or additional comments to the? If not, we'll open to further questions and Q&A to the rest of the audience.
ただ一つのこと。
Just one point I would like to mention. Earlier on, as Ms. Ishii said, UHC Day will happen in December. So this will offer a very good opportunity for Japan, for JICA as well. So the government representative, university research representative, and NGO representative, 3 people are here. So these 3 sectors would communicate the significance and meaning of UHC. What is the relevance to Japan? And viewed from international community, what significance is carried by Japan? In that context, various fields, various sectors, what should they do? I think that this UHC Day will offer a golden opportunity. It's a soul-searching day in a way. It's a day of reflection. There are hopes, but hopes must lead to actions and activities. By reflection, you have to cause some actions and activities. So that was the strong impression that Ms. Ishii's representation left in me.
Thank you very much, Professor Reich. We'd like to entertain questions or comments from the floor. We'll bring the microphone over to you, so please raise your hand.
Jenny, Alex. Microphone お願いします。
I'm Alex. Center. Just one comment, one question. First, wonderful congratulations to Professor Takemi, but to the entire group, Professor Shibuya, Professor Kigami, the World Bank for 2 years, and really the foresight to get to this point, because 2 years ago, this wasn't quite a movement the way it is today. So this has made a tremendous contribution, and all of us in WHO, from Geneva to here to the country offices, really very much welcome the collaboration and really look forward to working with you a great deal more. One additional comment that it's also to think about the other public health aspects of the benefit package. It's often becomes very medicalized, and for the first time, I think this is trying to get away from that, looking at both rehabilitation, prevention, promotion, and how to bring that into the political economy. And perhaps my question goes to, and prefacing my question is about equity, and it is that for the first time we've seen equity at the absolute center of UHC. And Professor Reich, you raised a very good question, which is really how do you fundamentally put the priority on the poorest populations first, which is actually very hard to do. But if you had any to turn it around and saying what are some of the key research questions as you see it, to somehow put that front and center in the whole reform process. Thank you.
Thank you very much, Dr. Ross. Let me just, if there's any other hand up at this stage. Oh, sorry, at the back. Oh, I'll take a couple of questions before we turn back to the panel. Please, can you say your name and 日本語でもよろしいです。日本語でも英語でもどうぞ。
You can speak in Japanese too. Takizawa from JICA. Thank you very much for wonderful, insightful presentations. I have a question to Professor Reich. As for Japan, or as for the World Bank, in response to the consequence of the joint research, you are obliged to help a developing world. I think that was a very strong message from you. How do we assist them? Especially in your presentation, you talked about UHC, which is a political process, you said. For us, JICA, or for the World Bank, up until now, we were involved with technocrats of health ministry. So at the highest level, it will be the health minister. But if you want to promote UHC, politician politics, parliamentarians, they are the people that we have to get involved. So as donor, can we do that? And if it is possible, what are the approaches? Do we have to do that, or should we do that? So I'd like to hear Professor Reich's views. Thank you very much. We will wait. Please wait for the question, the next one.
2つの簡単な質問で簡単に答え
The two simple questions, and I will try to answer in a simple way. First of all, JICA, Mr. Takizawa's question. Simply put, JICA and the World Bank, you read this report, what should they do? That's simply the question. So, Mr. Kodera's comment, when I heard it, in the end, what I expect, what I hope is that JICA could be a little more extrovert. They will go outside from the political, economic perspective. They should look at the situation from a little external elements. We are dissociated from politics, of course, people would usually say. But aid agency in Europe, JICA-like, most of the agencies have political and economic perspectives. They analyze that, they research that, they produce reports on politics and the economy. About 2 weeks ago, in the United States, USAID has that perspective, and the USAID has begun its activities from a political economic perspective. I was stunned. If USAID can do it, JICA can do it. So the World Bank gradually is also moving into the training of a political and economic perspective. The words, the notions and ideas and analysis are coming. So this is my response to Mr. Takizawa's question. Now, turning to Alex Ross's question. So once UHC begins, what about equity? How can we prioritize the poorest of the population? How can we come up with a policy prioritizing first and foremost the poorest segment of the population? That is indeed the political economic issue. The response is that it can't be done so simply or easily. Here and there, in some countries, it may not be prioritized the first, but the poor people, to the poor people, the resources are redistributed. There is a possibility of redistribution. Historically, there may be a time like that to do so in some countries. But in a revolutionary way, resource redistribution, that's not possible. So, as I get old, incrementalism is something that I consider all things. There will be opportunities of redistribution of resources in an incremental way. So it is incremental, the incremental possibility. But so it is possible to make progress as time goes by.
Thank you very much, Professor Shibuya, please. I think Takizawa-san's question was very good. Globalization has been enhanced, so it's not just the health problem, human rights or intellectual property, or there are power struggles which are involved, and it's inextricable. So you can't focus on medical or insurance per se. You have to analyze different situations and try to grasp the needs of the client. You don't come up with a solution and then try to cascade down from that. You have to create the solution first together. Thank you very much. Mr. Kodera, a word from you, please. I'd like to supplement to Professor Reis's question to Mr. Takizawa. Development assistance or aid is such that whether the other party would take ownership in a correct way is something you have to look carefully at. And if they take the right approach, then you have to get together with them to work together. And that would be the natural mission. It's been 4 years or so since I've joined JICA. I've been working for World Bank a little bit longer. When I was Director General of World Bank, when I saw that the insurance sector was weak, whether it's the Prime Minister or Finance Minister, I'd talk to the relevant ministers and I would say, you need to allocate more of a budget to this sector. And that was the job of the director of the World Bank. And so JICA is also a high-level institution. They can be more positive. It's normally the finance minister that's looking at insurance because they're not properly allocating recurrent cost. The insurance sector is dealt with not by insurance people alone. World Bank or JICA, this multi-sectoral, broad platform-owning entities can talk to high-level persons and to different partners so they can walk the talk and to work on these people. And when this is done, perhaps things will begin to change. But if they don't listen to you, you have to just pass that country. Thank you very much.
As for the World Bank, political economy, not politics, but political economy, that is an area we can't escape. President Kim, Governor Kim, is also taking this up. How to solve the problem? So we have to understand fully political economy. But it's not about the World Bank itself. Various countries can come up with the political economic solutions. And by sharing that, we can learn other countries' lessons and sharing with other countries. And we can make advancement, sharing and knowing the results of the various experiences. The next question, Professor Ushio.
His hand up early, so if I could, and then Dr. Suet.
Ushio from MHLW. Thank you very much for the presentation. Ms. Ishii and others, I have some comments and questions. UHC. For us, the word is well known, but for the general public, UHC is not a household terms. I think we have to be mindful of this fact. Relating to this particular point, UHC definition. It's very abstract. Precisely because of that, we don't know what is included. The other people may not have a clear agreement as to what is included. Provision of health services and the health system supporting and financial system to support that, as well as Ms. Maida's point, the public health kind of sector. I think these three pillars would be common to this area. We are going to have aging, and we have to have the long-term nursing care of the elderly. Considering these, UHC will also have to include the issues coming from aging and long-term nursing care. So if you continue your research, I hope that you will also take up the aspect of the elderly's health care. That is all. Thank you very much. Thank you very much. Sweet-sen.
Thank you so much for the excellent presentation and by Michael and the comments by the three wise ladies and gentlemen here. Michael, should we also learn from the US as you are already here? Of course, US and Japan are totally different historically, socio-economically. Obamacare Act on the table. Right? Very difficult to get it through the Congress. After got it through, case in Supreme Court, government shutdown, collapse of IT system, which result in the resignation of the health secretary. Yeah. And now Republican has already taken over the Congress, and they announced that the first thing to do is to abolish the Obamacare Act. I wonder whether, and you said that once, we move towards universal health care coverage, it's very difficult to go back. I have two questions. First, for our Japanese colleague, has there been any attempt at moving back? Not now, of course not now, but back 30, 40 years ago when you started to have universal health coverage. Has there been any political movement to move it back? Second, to Reich, what do you think as a political scientist and Americans, not a Democrat, of course, but as a, American intellect, what do you think the US universal coverage system can challenge what you said yourself, that it's very difficult to move back? Thank you.
Thank you, Dr. Suet. Two very excellent comments. Well, Michael, once again, you're on the hot seat, but would you like to... sorry, Professor Takemi. Takemi sensei, dozo. Gomennasai.
Dr. Takemi, Mr. Takemi, please. Keizo Takemi speaking. As a member of the House of Councillors, my response in that capacity is my answer to Mr. Suet. Economic and political and demographic changes. If we are to look at what happened in Japan, since the bubble has burst, or before the burst of the bubble in 1989, we should have done a major reform. And if we had done that, we would have been able to transition better into the aging society. But Japan, at that point, could not implement that reform. And some soul-searching on this fact is included in the report that has been given. Various vested interests in the medical provision services are there. And so they resist reform. And because of this, reform makes little headway. And when there are over 35,000 of insurance, the reform does not go well. And as a result, there's more aging, and a fiscal situation deteriorates even further. And the insurers, a premise for this, the employment relationship is undergoing major changes. And Japan is finally embarking on reform because we could no longer continue the way we are continuing. And so stronger political leadership is called for at this moment. Fortunately, the Abe government can exert that kind of strong political leadership. In the next ordinary session of the Diet, the integration of insurers in each of the prefectures are included in a bill, which is a major bill, and we will be submitting that. But what will be questioned when we do this is political leadership and governance. In our discussions in this session, I feel that as I listen to the discussions, political leadership and the respective countries' governance for nurturing and developing an UHC, global level, country level, and community level. On each of these levels, we need to see discussions conducted properly. And based on these, the respective governments, policy makers should make decisions bearing in mind the case of his or her own country. And in the international society, that is the kind of policy we should be promoting in UHC. That's the priority subject. I think it's becoming a priority subject. Thank you very much, Mr. Takemi.
まさにそれこそがこれからの大きい課題となっていくと思います。Michael, would you like to say a few words on the U.S. situation, Obamacare, and what lessons we can draw from that?
Sweet-sanの
Professor Sweet, I received 2 questions from him. What is my position on Obamacare? And the second point is what's going to happen in the future? Now, first question regarding Obamacare. What's my take? For me, I'm a big supporter of Obamacare. I want to say so. And we had a fight over 100 years, and at long last, we were going into the civilized nation after 100 years of battle. So, as Mr. Takemi explained, political leadership, he mentioned. So, President Obama created Obamacare, and he had the political leadership of drafting Obamacare. So, the second point, what's going to happen in the future? Would he have a good political leadership so he can protect Obamacare? That's the second question. That's very difficult. It's a very difficult question. Unfortunately, when I left my crystal ball, I left in the United States. I didn't bring it here, so I can't make any prediction. However, from a political perspective, if I look at the situation, once a benefit is provided to a group of population, to bring it back altogether would be very politically difficult. The Republicans have taken a strategy. So they have the control of both houses, Republicans. And if the Republican Party wants to commit suicide, they can retract Obamacare. It is possible that they can retract the whole of Obamacare, but that would be irrational political behavior. If you think of that, it is possible to have the complete repeal of Obamacare, but that possibility is, relatively speaking, less and less. Now then, relatively speaking, what is going to be the outcome? What's the numbers? About 10% possibility would I find in that. Partially changing Obamacare, it's possible, but the complete repeal of Obamacare, I think that possibility is in the vicinity of 10%. So I say it here. So empirically testable hypothesis, I know. So you can say that the professor was right, professor was wrong. So in 1 year's time, you'll be able to find out whether my prediction turns right.
Betting on 9 to 1. Thank you. 9 to 1. どうもありがとうございます。先ほどご覧になりました4つのグループ。
There are 4 groups mentioned earlier. Where the United States belongs is Group 2. So perhaps this is not 100% related to the income level. No. I think I'm in Group 3. With Obamacare, you're Group 3, and before Obamacare, Group 2. 40 million were not insured, were not enrolled. So you're finally in Group 3. You finally joined Group 3. Congratulations. So going forward, there are lots of things we'd like to talk about, but time is up. So thank you very much, everyone.
パネリストの皆様ありがとうございました。
Thank you very much, everyone. Could we have a big round of applause for those up on stage, and those on stage can now proceed off the stage. Thank you.